Presenters are Catina O'Leary and Ariella Herman. Dr. O'Leary, who we know very, very well, serves as president and CEO of Health Literacy Media based in St. Louis, Missouri, and is a member of the Roundtable. Under her direction, HLM's service network has expanded, and expanded well, to include some of the largest employers in Missouri, including pharmaceutical companies, hospital systems, business coalitions, and community-based organizations. She will be presenting this morning on HLM's community-based programs. Dr. Herman is the research director of Johnson & Johnson Healthcare Institute, which is housed at the UCLA Anderson School of Management. She will be presenting on implementing and evaluating a health literacy intervention in Head Start preschool community settings. So, Catina, 'tis yours.
Good morning, everyone. So I'm going to start to talk about the community programs that we've run through the Cover Missouri Coalition for the last year or so, which is really an extension of the work that we've done for about 4 years with the Cover Missouri Coalition on health insurance literacy. And I'm going to be a little scandalous, maybe, or not, because I'm not sure I'm going to use the word health literacy or the phrase health literacy again through most of this talk. And it's because they don't, right? So we are going to these communities and we're talking with them in a responsive way about interventions that are meaningful and matter to them. And they almost never say, oh, geez, bring us health literacy. Doesn't happen. But they ask for all these other things that they want that have components of health literacy, and that's what I'm going to talk about. I hope, though, as you look at this, you'll see elements of health literacy in everything we do, and I'm particularly excited about the discussion because as Leslie spoke about the work they were doing in libraries earlier, it really strikes me when you ask communities what they want and how to get health and wellness and educational information, they sort of bubble up with the same ideas everywhere. So it's happening in Oklahoma, it's happening in Missouri, it's happening in Georgia, it's happening all over the world, and it's the same kind of stuff that people do. It's fascinating in a certain way. So I've spoken here before about the Cover Missouri Coalition, but just as a grounding framework, these are the folks who have let us do work in health insurance literacy for the past 4 years or so. And they've had 3 goals. The big one was to lower the rate of uninsured Missourians to 5% by 2018, which is sort of laughable in this particular environment, particularly in Missouri as well, where we didn't expand Medicaid, and looks like there's no chance of that ever. But we worked really hard, and the cool thing that we did is we ended up with about 900 partners that participated pretty actively. We have coalition meetings that include 200 or 300 people every other month. We have webinars that are really well attended. These folks show up. They're navigators, assisters, people who are at various levels of organizations, and they come with questions that are so big and so complicated that the folks from CMS bring their books and they have to flip through and find the answer and send the questions back, and it's the real deal. These folks work in communities all the time. They are community. They know what they're doing. But our role was the technical insurance provider for health insurance literacy. So we brought health literacy to all these folks, and we helped think about how they do their work. In our first 3 years, really what we did is the standard health literacy activities that we all talk about here pretty traditionally. So we made materials. We've got all these wonderful worksheets about what you need to know to enroll in the marketplace, the words to know, glossaries, what questions should you ask when you compare plans. We had this calendar because people said they wanted a calendar, and every month we have topics and educational informations and graphics, and we worked to make sure it was in plain language and really responsively designed in that way. But then in year 3, one of the things we realized is that while it was important to continue the work in awareness and other components of the technical assistance that people were provided, there weren't a lot of people in Missouri who didn't know that health insurance was available to them and that they were theoretically supposed to have it. So people who were left uninsured were folks who either were in the coverage gap and couldn't afford insurance, it wasn't affordable and it wasn't going to be affordable, or it was not culturally aligned for whatever reason. They didn't think it was important. In Missouri, a lot of not cultural alignment meant they didn't think their health was important at that time. They were making other choices, or they didn't even want to be forced to get health insurance, right? So these folks were sort of saying, we get it, we get it, we get it. There's not a billboard that's going to convince me to enroll. What else do you have for my health? So what we decided we wanted to do is ask the folks at the Missouri Foundation for Health to let us actually go into communities in a responsive way and talk to them about what would be helpful toward health and wellness. with the framework of health literacy, because that's what we do and what we understand. So we want everything we do to be health literate. We want to layer and infuse health literacy in all of our activities. So we were funded to do these for pilot communities for a community project. So our job was to support their knowledge about health and healthcare, however we did that, however they wanted it. And we wanted to help people make informed choices for their family's health, whatever those things are. We thought it would be really great if we got some more people to health insurance, because we don't know what's going to happen, and there are unexpected events in people's life, and insurance from a value standpoint is something that we think is important. But we also knew that people were going to make choices, and we couldn't do a whole lot about that. But we could get them healthier. We could get them attached to care. We could talk with them about FQHCs. We could also talk to them about prevention and wellness and all the things they can do without coverage. And the overarching goal was engage community around health and health insurance through strategies that lower barriers to health. And our framework really was to meet these communities where they are and infuse health literacy. So this was about them and our responsiveness to their requests. So this is our planning process. We had 4 phases just to even get started. The blue and green and gray little material is what we took out to communities and also to our funders to explain this. It took us about 8 months to get the funders to even understand why we were doing this complex process to start. What they wanted us to do is just go do health literacy. And what we continue to say is we can go do health literacy. That's what we've been doing. But people have to want health literacy, and they have to want health education, and we have to actually talk to them about that before we just start doing. Otherwise, it's not actually community. It's us doing what we want to do. And that's kind of cool because we're smart, but they're smarter than we are about what they need and how they want to get it and how they want to use it. So our goal is, again, we had 4 phases. The first was an early planning phase. So we wanted to select 4 communities on criteria and a decision tree that I'll show you in just a moment. And then we wanted to think about how we were going to track our activities and evaluation measures. So there's the outcome of what we did, but a bigger thing in these communities is how we did it, how many people we talked to, what kinds of questions they asked, where we went, how much engagement there was, what the connections were. So you talk to Lila over here, and Lila tells us to talk to these other 4 people, and you can't do anything until you talk to all those 4 people because they're all the gatekeepers. And the gatekeepers in communities are really complex. There's not usually just one. Lots of gatekeepers for lots of different things. So it took us a long time to figure out how to track and evaluate and make sure that we could keep up with these things. The next phase was the community organization goal. So we had 2 staff members from our organization that were charged with each of our 4 communities. So there was a frontline person to actually go and be the hands-on person so that folks in community didn't have to remember a bunch of people to talk to. We really tried to coordinate all the services. And all the people from the Cover Missouri Coalition are theoretically accessible to all the people in these communities. So if they want media training from our partner at Fleischman-Hillard, we can help them with that, but we didn't want them to think that they have to call our contact Brandy at Fleischman-Hillard to get that. They should be able to call me and ask for what they need, and I should be able to help connect them. It shouldn't be hard for them. It can't be hard for them. If it's hard for them, they won't do it because guess what? This is not their real job. I'm the one that got the money, right? My money, my responsibility. I need to partner with them to do something that's usable. So then we wanted to engage and identify with key stakeholders and organize planning meetings to get this started. It says planning meeting here. There were lots of planning meetings in all of these communities because they sort of snowballed, and that's how it works. We did a community assessment with the key stakeholders and partners. So we had a script that we went out with, a question guide, and we talked to people in every community about their needs, their concerns, their values, what their big issues were, and then we helped them brainstorm with us about what we could bring and how we could be helpful. The interesting thing is some of these communities already had a lot going on, so they didn't actually need us to bring everything we thought. Some of the communities didn't have much going on at all, so they wanted different things, all of it right now. So part of our selection process was to select diverse communities so we could do some evaluation and measurement about community resources to start and what that path looks like as we go along. So we did that, then we presented findings and identified their priorities. So they helped us generate the priorities. And then we continued with strategic activity planning. So they say we're concerned about certain issues, which I'll show you in a second. We have to figure out what activities connect to those issues. What can we actually do based on what they say? So if they say we've got an obesity problem, lots of different strategies for that. What do they want to do about their obesity problem, and how do we help that? And then our job was to coordinate and implement activities. We had a tiny bit of money for them from the foundation. It was really interesting. The foundation gave us about $5,000 for each community. It was baby amount of money. so powerful and massive. They thought so hard about how to spend this money and what they wanted to do with it and who should get it and what they should do. Little bits of money are so meaningful. So how did we choose them? This is one of the questions people always have. So this is the state of Missouri. The parts of the communities that are in color are all the Missouri Foundation for Health Service areas. And just the way that the Conversion Foundation works, they've got this cutout that's not theirs. It belongs to another foundation called the Healthcare Foundation of Greater Kansas City. So Healthcare Foundation stuff is not, we can't step into their territory with MFH funding, and that just is what it is. But the MFH areas are the ones that are highlighted. So what we know is if you're in St. Louis or in central Missouri, you get a lot of resource because you get to go to all the meetings that are there all the time. That's where the universities are. That's where WashU, St. Louis University, University of Missouri are. Tons of meetings, tons of organizations, tons of doctors. All these folks are constantly implementing activities. But if you're in Monette, Poplar Bluff down in the Boot Heel, they call it, or up in the Northeast, it's really pretty hard to get there. So to get to a meeting from Hannibal, Missouri, down in central Missouri, it's a whole day just traveling, coming and going. So if you have a meeting where you're not paying for their travel, they don't have any way to get there and get back and cover their staff outages. So these are folks we don't regularly see from a professional side as well as obviously down to the community level because it's just not strategically possible for them to spend all this money all the time. So you can host webinars and do all those things. But what we know about privilege and power is the people who actually get to be in the room are the people who get the resources, right? So those folks don't get to do that all the time. So we wanted to make sure that we hit them. So we went up to Hannibal, all the way over to Monette, down to Poplar Bluff, and then we did one in the center because we wanted to have this diversity across. These are the categories that we looked at. So we wanted people who were uninsured because this was a health insurance literacy project. So if everybody was insured, sort of didn't work. We wanted people, our communities that had a high level of folks under the federal poverty level. MFH has some priority populations, and so we were interested in identifying those and giving them some expertise. And then we wanted some amount of existing relationships. So we didn't want to go into communities that just had nobody knowing anybody at all. We didn't have enough time to start completely cold, so we had to at least know one person at one organization who would say, yes, please join us. But then we invited them to take part in the project. This was really important. So we selected them, but just because we selected them doesn't mean that they're the community. They actually have to select us back. And we were fortunate that everybody selected us back, so we didn't have to have a lot of asks, but we had to have a lot of meetings to ask a lot of people the question to make sure they selected us back before we started the work. But these are what our final communities looked like. So Hannibal, Monette, Poplar Bluff, and Salem. You can see they're mostly small. So some are really small, and some are a little bit larger. None are completely tiny because, again, there have to be enough people that you don't make yourself a nuisance. They have different levels of minority populations. I want to point out Monette, 24% of the population in Monette was Hispanic. We were really interested in getting to a community where people had a large population that didn't speak English as a first language because we wanted to think about how our interventions worked differently and be able to compare across. So Monette was that community. And just to say, in case I don't get back to this later, they've been fabulous. They've been such a fabulous community partner, as have all of them. But this language barrier, even though we only had one Spanish speaker on staff, was not a barrier. They brought their people. They were really excited to be asked. And some of the things that I won't say in the findings that we've learned is that these folks were having different problems even applying for money, funding from the foundations and other sources, because the folks on their staff, while they spoke English, some of their structural issues didn't help them with the funding requirements that they needed to actually fill out the forms. So we've been able to bring some of those issues to light and start conversations about changing processes so communities like this that have a different level of vulnerability aren't overlooked. We looked for communities with high uninsured rates and poverty rates. You see what those are. So people ask, how do we know that there are health literacy issues in communities? And what we would say is, first of all, we know that 9 out of 10 folks have a problem with health literacy. So if you pick anybody out of the phone book, in general, you're going to get a group of people that have a health literacy problem. But in communities that look like this from a social perspective, they're undereducated comparatively, high levels of poverty, high uninsurance rates. I don't have to run a schedule to figure that out. So these are the kinds of things we did. We had meetings with and interviews with our partners to get this going. We did a media and awareness campaign that took us back to the beginning of health literacy media, where we did a huge awareness campaign in Missouri to help people even know what health literacy was. We've gone back to that, and we've helped provide programming for the local newspapers and such so that they know what to even talk about health issues. So we're talking about health issues in a health literate way based on what communities tell us that are important. So mental health, dental care, all kinds of issues like that pop up. We've done a bunch of events and programs. We create shared resources, and we give those out to all the communities because they need the same thing. Tons of trainings for professionals so that they can work with the people they serve, but also people, frontline folks in libraries and other places. We've gone and given them health literacy consumer level training. And then we also have folks, they got to know who to call. So these are the sort of early partners across the 4 communities, but you'll see that they're diverse and that they're big organizations and small ones. Health centers show up, school districts, all those kinds of places. The Missouri Foundation for Health also has an effort called Healthy Schools, Healthy Communities. They were in a couple of the communities, at least one, and when that organization was there, that method, they had a lot of resource. And so that was important to us to look at low resource communities versus high resource communities. So we wanted that comparison. So just some quick key findings I'm going to go through for all the communities. You'll see lack of awareness about resources, lack of coordination. They say these things. This is not me providing a judgment. They tell us we don't know. Professionals say we don't know who to call. We don't know what to do. We don't know how to connect this. We don't know how to talk about health insurance in the marketplace. The materials that we have to have are really unclear, and we've got a big problem with mental health. That's what they told us in Hannibal. So one of the things that we did is we used the money in Hannibal to create a resource directory on a smartphone app called Johigo to connect the community services that they need. So everything's on there for them. They picked that out. They worked together to create it. We brought the vendor in, and we have this thing. So in a month, 3 weeks, I think, Johigo, the newspapers, all the community partners will come together, and we're going to launch this app, and they're going to celebrate what it is. We'll train the providers on how to use it. We'll train the public. We'll do a big media thing. I mean, as big as it gets in a very small community. But this becomes really important to them because they drove this. The other thing we did, they had some sort of health-related issues that related to food. We had a connection with one of the highest-ranking female chefs in the Coast Guard who came and did these food demonstrations for us. In this particular community, there are lots of people who go to the military, so that's one of the main career paths for kids. So bringing somebody on a non-traditional sort of military path was really interesting to them because they were able to see women in the military performing in a way that was not sort of a soldier role doing this thing. And we talked about, so careers, but also cooking demonstrations, and then easy make-ahead meals, so crock pots and all those things. We gave them food along with it so that they could go home and make these things and the recipes. So simple stuff, but really important. So here are some of the successes. We talk about technology bridging barriers. The presentations are sort of one-off, but they add value and exposure to other things. This is about connecting, linking things together, and this collaboration is really important. They already are telling us what they want for this year, so they really want us to talk about mental health services and substances and all these other things. So they're really driving an agenda, and we're being responsive to that. So the next one is Monat. They talked about tobacco, obesity, diabetes, cardiovascular disease, drug use, dental and vision services, particularly in the Latino population. So key activities for them, we created a community walk called Monat on the Move. So we have 3 levels of fitness areas, 20, 30, 40-minute walks. We connect that to the farmers market, and we talk about health insurance information there as well. So we put it all together in place for them. We go walk with them. We bring food. We bring vouchers. We cheerlead. We do all those things to keep them moving. At the same time, they also were interested in very traditional health literacy information and health insurance literacy training. So we trained school district staff and also employees at one of these big corporate companies in the area. So really looking at sort of multi-layered interventions. So they're really interested in face-to-face meetings. Texting was a really big thing for them. So in some of these communities, they weren't interested in our phone calls and our reminders. They wanted communication like this. Finding the social nodes was important, and the advertising is sort of a big deal. I have to say that we started with like 4 people at the first walk, and by the end we were getting 40 people every week. Poplar Bluff had these issues, so access to food, vegetable, transportation. This whole distrust toward health insurance is still a big thing, and they have trouble getting doctors that are specialty folks. So these are the things we created in Poplar Bluff, a wellness fair. We had giveaways, Fitbit, fitness trackers, walks, all those things. We also did a trail run and gave people $20 vouchers to participate. So here are some successes. Again, trust. Hello. Well, you turned it off. I didn't even know it was on. Apologies. So the notes for next time, they're talking about playgrounds and trail connections. They're also interested in heroin and prescription drug abuse and smoking. So these are the issues in Salem: food insecurity, poor nutrition, physical activity, heart disease. You can read all of these. So there's some consistency across communities. So we also brought the chef back to Salem. Salem was close to Hannibal, and so it was convenient to do this in one trip. But the other thing we did is we provided the Smile-mobile, so they provided services to some kids and adults for oral health care. They talked about their health care and also overuse of the emergency room for dental services, so that was important. It was really important that they didn't have any dental care in their community, so people were driving a long way. They'd never had the Smile-mobile, so this was the first opportunity that they even knew that this was a possibility. So that was really important to them. And there was a partnership with the Community Health Center. And they really advised us that they weren't interested in, this is funny, you get like big communities and you bring everybody together and they're like, oh yeah, but not all of them. Well, I just want you to ask this small group. So what's the balance of like who actually gets to be the decision maker? We have to figure that out. So just my takeaway messages. I wanna leave you with this idea that community really is multi-layered, and there's not a person in a spot that gets to say, yes, we're in, yes, this is community, yes, this counts, and go for it. So lots of conversations that continue as projects and relationships evolve is really, I think, key when you talk about community. And this sort of vague concept of what community is maybe a result of the fact that it's not a clear sort of one place that we say that's it, that's the community. It's complex. We want to build sustainable relationships, and that takes time and respect. One of the biggest things that I see across the board is this need for flexibility as a core competency. So again, we don't get to drive the agenda, they do, and it's not always the agenda that we want right now, but we all get around to the thing that we think is important later. If you're right and it's the important issue, you get to it, but you get to it on their time, not on yours. And I think this gets to the problem that you were talking about earlier about motivation and how to engage people and retain them and keep them going. If you actually do what they think is important in a way that's responsive and reflective, you sort of get there differently, and it becomes we, not they. And then the final thing I want to say is our agendas don't always look the same, and we don't always talk about the key issues exactly in the same way. So this idea of health literacy is really important here. I didn't call much of any of this health literacy, and that's purposeful because they don't. But it is, I think. We do health literacy, and these things count. So we want to teach them our words because maybe those words have some power for them, but we don't have to start in that place. And so how do we make the conversation broader and bring people into the language together and make the words all of ours so that we are all healthy, which includes health literate? Thank you.